I don't think there's any better compliment than being acknowledged by your peers for a nomination for an award like that. So, to me, that's all the introduction you need. Come on up here. And if I touch that, that should work. Working collaboration, is it? Collaboratively. Police and ambulance triage.
Did I spell it right?
Oh, it's probably. I've got Catholic dyslexia, so
Oh, that's right.
yeah.
I can't spell us, Mick.
I know, I can't either.
Terrible.
Okay, good.
Thank
You're
you.
on. You won't be any questions. She's got to go to the airport.
So thanks, Brendan, for that generous introduction, and thanks very much for choosing to come and have a listen this afternoon. It gives me great honour to be invited to come and talk about, one of the really exciting things that I think that we're doing here at Ambulance Victoria. And I'd like to take you on a little bit of a journey about what we did in this space. But before I do, I would like to acknowledge a couple of my colleagues who are not here today. So I was lucky enough to inherit this project and see the last part of it through and some of the transition into different spaces that we're working in now. But the inception and the concept of a police and ambulance triage team or working collaboratively with another emergency service really came from Jerome Payton, who was the group manager at the time, and Libby Langdon, who was one of our team managers and had an affiliation with Victoria Police. So I'd like to acknowledge them today around the project. So I'm going to take you on a little bit of a journey around some of the concepts and the way that the PAT came about, the pilot that we did, and then an ongoing evaluation that we did, and then, where it really lies today. And I think, there are different platforms of service delivery occurring in all of our organisations, and hopefully the journey that we went on will give you some inspiration or some ideas around how you might look at your own communities and how we deliver a service in those communities. So we are looking at a changing community. We've got a changing workforce, but we're also looking at changing communities. And when we think of the way we deliver and the changes in ambulance over time, we often think about, the fleet, the vehicles changed, the stretchers changed. We think about the different equipment that we think of that are going to give us advances, so medical technology that will improve patient care, or, faster. We've got paramedics on motorcycles in Victoria, so can we get there faster? Is that a better, model of delivery of care? But the thing that I want to talk about today really is understanding that the community that you're caring for, and that perhaps, the intervention or the innovation needs to come out of doing it differently and not just thinking that, better is faster or, a new drug or a new piece of kit. Whilst that's exciting and it gets lots of glory, there are somewhat times I think we need to go into our communities and say, well, what is the community that we're trying to serve and what are the needs in that community and how can we better deliver that better? So we're about collaborating for success, and nicely the theme of the conference over the last couple of days is all about collaborating for success. And the police and the ambulance triage team was specifically aimed at improving performance utilisation using an integrated approach with Ambulance Victoria and Victoria Police, and building on the appropriate response to specific case types that best meet the client's needs. So in 2015, those of you that were there last night, knowing Karen's in the room today, so Karen and her team, won an award for a large piece of work into the dispatch grid review. So as part of that, we used that data and the VACAS data from our patient care records, and we did some analysis of the clients and the patient types that we were looking after in the CBD. Over Fridays and Saturday nights, and what the type of events we were going to, and then what the final disposition or what the outcome for those patients were. And we used that information and analysis collectively with some information that was coming out of Victoria Police to say that they're making lots of requests for ambulance on these nights. It came almost as a complaint in the first part because they were calling ambulances for low acuity events and waiting a long time for the ambulance to turn up on scene. And conversely, we in Victoria, we have a paramedic first policy, so the safety and welfare of our paramedics is utmost important, to the detriment or to the exclusion of the patient sometimes. So you have to be safe first. So if you're anxious or concerned about a scene or an event, or there's information there that is potentially going to be harmful, we ask our paramedics to wait and request police before they enter into the scene. So it was causing some operational challenges for both organisations in the space, for resources being tied up waiting for other agencies. And this happened on those nights in the CBD, we all know, where demand is high and the resources that are at premium. And so it was really, can we do something different in that space? So the event types that we looked at in the information, and these pictures, will be familiar to many of you out there. This is kind of the type of work that our crews were going to. The data analysis showed that there were, overdoses, brawls, intoxicated patients. We looked at the vital signs of the patients, and many of them were low acuity. There were a couple of serious patient groups in there and some serious trauma, particularly related to assaults. But for a lot of it, it was the police wanted our help with something. The Victoria Police have a policy that they can't interrogate somebody, or they can't question somebody, interview somebody, I think is the new word they use. They can't interview somebody without them having medical clearance if there's something wrong with them. So often we'll be called to go, well, is the patient okay for us to take them, etc. So the data analysis showed there were lots of low acuity event types. So the objectives that we came up was, we thought we could probably work together. We could determine the effectiveness of a joint ambulance and police operations unit, which would improve responsiveness, to these events, so we wouldn't be waiting on scene for the other agency, and would provide an early assessment on whether hospital transportation is required, so potentially reducing, the need for a stretcher ambulance to come along, and also improve the efficiencies of both organisations and their time utilisation. So where do we do it and how do we go about it? So the initial memorandum of understanding, or the plan, we used a fully equipped Ambulance Victoria non-stretcher vehicle, so one of our team manager type response vehicles. We had an experienced ALS paramedic on there, and this was this was crucial for the clinical decision making and that senior leadership capabilities that we wanted the paramedic to have, and we also wanted them to have some exposure and experience in this space. There were 2 Victoria Police officers, and in the first part of the rollout of the project, we actually used members from the Operational Response Unit, which is a special group that are used to dealing with the community and the public and that type of patient. And then in the interim at the start, we also had a second paramedic in the Police Operations Centre, so the Divisional Operations Communications Centre, to help with that liaison. So the paramedic would have an ambulance radio on them, the car would have an ambulance radio, the 2 police would have their police radios, and so the information would be coming in from police having low acuity events that their brawler van or something might have been up to, or they knew about something, or and a call would come through the ambulance 000 centre, and that would then be relayed to the team via the 000 centre. The DOSC, or the paramedic in the DOSC, was not able to dispatch ambulances at any point though, so our dispatch of our ambulance still went through our 000 call centre. It was really a liaison. And then you can see the red square in the CBD area. So we were very specific about the area that the unit would respond to, so that it didn't get dragged out on those busy nights into other work that was going on in the suburbs. It was really about the CBD and some parts of Yarra. So for 6 weeks we gathered some data and we compared the jobs that the PAT crew went to. So they worked every Friday and every Saturday night for 10 hours. And so we compared the events over that 6 weeks with 12 months prior, and we looked at how the proportion of cases where a stretcher ambulance was responded, and that reduced slightly, although interestingly the first criteria in our plan, or our project of how it would operate, was that you had to dispatch a stretcher ambulance at the same time that you dispatched the PAT vehicle, and we've subsequently changed that, and you'll see the difference that that's made down the track. But in the interim it was, we're not going to dispatch a stretcher ambulance at the point of dispatching the PAT crew. The median total case time reduced from 74 minutes down to 62 minutes during that pilot period, and the case time for PAT cases, so it was up around 63 minutes was the average time time for a case for patients prior to this type of patient with a stretcher vehicle, and that was reduced down to 31 minutes. So that's really doubling the efficiency. And then the total scene time, there was not a lot of difference between the total scene time, but we saw a significant improvement in response time. So response times were about 5.9 minutes because they were really close by, right? They're in the city, they're there and they're available. So the outcomes of that 6-week pilot were that staffing the resource needed an experienced paramedic that was confident. So we noticed a difference in performance depending on the capabilities and sometimes those softer skills of the paramedics that were on the truck. Working with the VicPol, so staff felt really safe. And they felt capable to enter into these scenes, and they weren't delaying that response. And the enhanced relationship between what ambulance was doing and what VicPol were doing. The nice thing around it was that the police that were rostered to work on the PAT crew, and that changed every Friday, Saturday night. So the police don't roster their staff to a particular unit. They roster 30 people on night shift, and then you turn up for a briefing and you get allocated different jobs for that night. So they had lots of different people coming, but the roles of the police there were to protect the paramedic at all times. They weren't to do police work. They weren't to apprehend people. They were there to have the back of the paramedic. And we had some challenges in the first part when you would have police, sergeants and superintendents in the field who would direct the PAT police, to do some police work or do something, and we just had to come over some of those challenges. The primary role of those police there is to make sure that the paramedic is safe and that no one's going to hurt that paramedic. So following that, we had some recommendations that we should continue over an extended period to have a look at if we redefine some of the event types we sent the car to, and we redefined whether for the low acuity events that we knew that were low acuity at the start, so code 2s and code 3s, should we dual dispatch a stretcher vehicle, or is it reasonable because we've got 2 police on the vehicle that we can just dispatch the PAT vehicle and they can assess the patient in the interim, and that we weren't sure that we needed additional staffing in the DOS, so we did an evaluation over the next period of time on the efficiencies of the PAT resource when the DOSC was running, or the paramedic in the DOSC, and when it wasn't running. And so over the next 12 months, we continued to operate the unit, and I've just got some information which I think is interesting to have a look at, what we found and where we're leading to now. So we did 263 cases over the 12-month period on a Friday and a Saturday night. We changed the dispatch criteria so that if it was a code 1, which is an emergency, and we don't send the PAT to lots of code 1s, but if they're by far the closest car, then absolutely we send them along, and then we'll back them up or dual respond a stretcher vehicle. So for code 2s and code 3s, we sent the PAT car alone to make an initial assessment, determine the clinical acuity of the patient, determine what needed to happen for the patient, and then they would request an ambulance as required. And we knew in that instant that, that saves our stretcher resource because we know that the patient needs to be transported, so we can be more efficient about sending the next resource and getting them back to the hospital. So interestingly, the average age of all of these patients was 27. The patients were twice as likely to be male than to be female. The average heart rate, I just thought some of the clinical features were interesting. They were clinically pretty well. So the average heart rate was 92, the average systolic blood pressure is 120. The average GCS was 14.5, and I thought it was a weird number and you can't really have that. So, for the most part, our patients were GCS 15 or 14. There were very few patients that had a GCS lower than that. And then when we go to have a look at, what kind of work are they doing and what are the events that they're turning up to? And so we assess that based on, drugs and alcohol. So was the patient intoxicated as the final assessment? And this comes out of, so we did a manual evaluation of the 263 patient care records, which were written on paper. So we now have transitioned into an electronic format, but we thought that it would be quicker, and the idea of this was to get our resource into the field as quickly as possible, and so the paper PCRs were how we went in the first instance. We measured them on whether it was a medical complaint, whether there was a mental health illness, whether there was minor trauma or significant trauma. And significant trauma is at the discretion of the paramedic filling in the PCR, but there was still, so if someone had a sprained wrist, they might have written significant trauma because it's an injury, whereas someone might have a bruise or a scratch and they might make it as minor. So it's a bit, it's not clear exactly which types of injuries fall into those categories. But overwhelmingly, most of the patients were intoxicated. And the next overwhelming assessment at the end of their disposition was that they had some kind of traumatic event. And you'll see there's a few medical events in there and quite a large portion also of mental health patients. So not surprising when we think about what we might go to in the CBD on a Friday and Saturday night, but certainly a large cohort of patients, that probably don't need an emergency stretcher ambulance or don't need to be filling up the emergency department bays at that time of night. So how efficient was the PAT vehicle? And so we can see there that we categorised it into, did they need an ambulance transport in the red? Was no emergency care required? So did we manage them and let them go home to themselves? Do we manage them and they didn't actually need to go anywhere? The other, which is the purple, is did we put them in a taxi? Did we put them on a tram? Did we get a friend who was sober with them to take them somewhere? The police transported some patients back to the divisional cells and then a group of patients refused. So that would be if we said that we think you need to go and we think you need to go to hospital, they're adamantly refusing. So overwhelmingly, we reduced more than 50% of these patients didn't need transport to hospital. In fact, 36% of patients in this cohort needed transport to hospital. So when you're thinking about efficiency of, a stretcher resource versus, that platform, it's a really good saving of resources and efficiency. Violence is something that we're all talking about and ongoingly, and we were very concerned from right at the start of this project, were we opening up and exposing our paramedics, to more violence. So these you see on the news, it's always in the city, it's the brawls, it's always in these spots where, you've got lots of young men predominantly, but where alcohol and other drugs are involved. And so we spent a lot of time working on what our safety briefing would be. We developed a safety briefing that was a checklist that you'd have a conversation at the start of every shift with the police that you're working with, and you worked out who was going to be who and who was going to do what. And our paramedics wore high visibility vests, and the police wear high visibility vests as well. They have flak jackets on, but that's part of their standard uniform, and we're not in a space where we're going down to putting flak jackets on our paramedics. So it's standard high vis vest visibility and standard PPE equipment. What's really nice to notice, so we map this into where there are mentions of violence on the patient care record. So what's really, and we broke that down into, did people feel verbally threatened? And our paramedics are good at writing stories. So if someone's being a prat to them, they write it on their PCR. And because it was a paper PCR, it was easier to get some of that information out of it. So really nicely, the majority of patients were really nice. They weren't violent towards the paramedic. They didn't yell or weren't verbally abusive to the paramedics. And there was actually a really high number of non-physical violence. We had one paramedic who got assaulted in the entire time frame, which I think is really interesting when you think about in the non-PAT space, the number of, on a Friday, Saturday night in the city, the number of, we have a hazard incident reporting system, but the number of times you come in and have a look at, hazards that get reported. So, if you think about why that might be happening, I'm not 100% sure. Is it because people feel, they're going to be nicer because the police are standing beside the paramedics? The other thing to consider is we all feel, we're all human beings and we all feel anxious, and when we feel anxious, we get defensive. So are some of our paramedics nervous about going into these scenes and they don't really realise that their own body language and their own defence mechanisms, they put them up before they even get there. So are we confrontational before we even get to some of these scenes, which is another whole piece of work in itself. But it wasn't any less safe than any of our other platforms of ambulance. So what's next for the PAT? So ongoingly now we are, the other interesting thing which I didn't capture on here was the efficiency of when the paramedic was in the divisional communication centre, the police centre and not, and there was no difference in the efficiency. So there was no difference in the number of events that the PAT car was responded to. There was no difference in the number of times whether the patient was transported or not transported. So what's next for us? We've rolled our PAT into, we're continuing to roster it on Friday and Saturday nights. We don't have a paramedic now in the Divisional Operations Centre. We've improved our case time and efficiency and the resource demands on both of those organisations. The efficiency of non-transporting a great proportion of these patients, to the hospital, or having previously the police sick or waiting for ambulance, so the police will run them up to the emergency department. So we've seen a lower incidence of emergency department presentations. And it's just improved that ability to provide a different service, but continuing to deliver a high quality of care outside of those hospital walls. So we're doing some work now with Victoria Police about other times and other places around the state where this kind of platform might work really well. And one of the times that we rolled it out just recently was in our Chapel Street in our police breakdown, because they're really invested at the moment in how to make our communities safer. And so they're doing some work where they come into certain hotspots and look at alcohol use and drug use. So I'd just like to play a little video of where we're at now and what's next, if it works.
Drivers aren't getting the message. That's according to Victoria Police after their latest Chapel Street sting. Overnight, 5 were found behind the wheel with an illicit substance in their system, and a worrying 1 in 80 drivers were over the alcohol limit.
People aren't getting the message. If you're impaired by drugs or alcohol, or you engage in distraction offences including mobile phones, the chances of trauma, including death, are increased.
Off-road sniffer dogs helped spring 7 people for drug possession, while in a first outside the CBD, paramedics and police rolled out their combined triage team to fight a rise in violent drug-affected patients.
I would feel safer with 2 policemen next to me, yes. It's not the be-all and end-all. Often these patients are multifactorial, so it's not just about safety, but it's about the multifactorial nature of what's wrong with them.
The sting falls under Operation Safe Night, established to combat Melbourne's alarming rate of drug overdoses. 3 people died in January after ingesting a synthetic pill sold as MDMA. Police admit an alert warning system is needed.
2 of the harm prevention pillars are reducing demand, reducing supply. If we can do that in partnership with Ambulance Victoria and others, we actually stop people being hurt, and that's what we want.
An SMS warning system similar to those used in bushfire emergencies is currently being considered by police and our politicians. It's reignited debate around pill testing, which already has the backing of the Greens as well as the Alcohol and Drug Foundation.
That's it. Thank you.